Hello, my name is Jonathan Burke, and in this tutorial we will be looking at the preoperative patient evaluation. Okay, so the lecture objectives. All patients should have a history taken, a thorough examination, and an investigations that are specific to this patient. This shouldn't take long, and if you practice this, one can do this within 5 minutes to 10 minutes. So after this, you should know your patient well. Then there should be a risk stratification for what are the risks for this specific case. It's not just another cesarean section. Next step is determine the urgency of the procedure. Do I proceed with this case? Do I delay? Or can I refer this case on to the next level of care for medical care, intensive care, for whatever specific investigations need to be done. Fourthly, optimization of my patient. What can be done to improve the patient's condition? Is there anything before we start the case that I can do to improve the patient within the time that is available? And then lastly, choose the anesthetic that is the safest. For the majority of patients, this will be a spinal anesthetic, but you have to know the contraindications and then how to perform a general anesthetic and prep the patient for a general anesthetic well. Okay, so just a slide on timelines to give you an idea of how this would proceed and what is to be expected, especially in the emergency sort of scenarios. You'll take a history from the patient, examine and run some investigations, and all of this should be fitting into this time frame, especially for the emergencies where it should, internationally, the standard or the guideline is that the baby should be delivered within 30 minutes from the time that the obstetricians have decided in the ward, in labor ward, to do the Caesar. Okay, and then one can ask, should I discuss this case anymore with the senior, or am I satisfied with my evaluation? Should I refer this patient? Can this patient be optimized? And am I going to do a spinal, or in a small group of patients, a general anesthetic? So what are the evaluation priorities that we should focus on in this 5 to 10 minutes for history taking and examination? Well, you've got the maternity case record and the maternity care perioperative record that can guide you as to what specifically in the history and the examination should be priorities. In the history, it is important to consider the urgency of the procedure, review the patient's obstetric history, and then especially or specifically important is that, is this patient at risk of bleeding? And we're going to look at that closer just now. Medical history, anything in the medical history that comes out and that's been identified in the antenatal clinic, like obesity, cardiac disease, which those two would often be indicators to transfer this patient or refer this patient to the correct level of care. And then previous anesthetics and surgeries that the patient might have had, especially the history on previous cesarean sections, the patient's experience of these complications from previous cesarean sections. And this might have been patient ending up in an intensive care unit and spending a prolonged period of time in the ICU setting. When we move on to the examination, all the general components of an examination, but specifically focusing on the vital signs, the baseline blood pressure, heart rate, respiratory rate. These are valuable to have as a baseline to move from and work from. We're going to look at the airway, and then cardiac and respiratory reserve will be important. And then lastly, investigations. Here, only what is indicated. We will have a baseline HP to work from. Patient would have had urine analysis tested as Bedside, and then most of the other tests will be guided from your history taking and examining. And not every patient should have lung functions and cardiac echoes done before their surgery. So next is important to discuss with your obstetric team the what, the why, the when, and the risks. Decide early on the urgency of the procedure. With red cesarean sections classified as emergencies, immediately threat to life of the mother and the fetus, especially with fetal distress, for example, due to APH. Yellow cesarean sections, maternal or fetal compromise, which is not immediately life-threatening, and then the green Caesars needing early delivery but no maternal or fetal compromise. And here you may have a bit more time even to refer the patient, discuss and optimize. But when it gets to the red Caesar, the decision to delivery interval, which means from the time the obstetrician has made the decision to deliver the baby in the labor ward until time of delivery should be within 30 minutes. And this is what our aim would be for the red cesarean sections. So again, use your maternity case record, your maternity case care perioperative record to guide you as to what specifically needs to be investigated further, whether it's part of the obstetric history, medical history, any medication the patient might be on, and focus your attention on previous surgeries, complications, and get that. Patients don't always offer this, but if you look at the notes, somewhere in there you will find the what are the priorities in the history taking. Examination of the patient will take you back to those very basic principles of inspection, palpation, percussion, and auscultation. And I've added ultrasound because we're seeing this modality involved and in the perioperative care of patients more and more. But by no means does ultrasound in 2022 replace the need for a very good clinical evaluation and clinical skills. So a general examination, you're going to do it yourself. Don't just go on what was handed over to you by the obstetrician or the obstetric team. Evaluate each patient yourself. Go through the general examination. Don't miss the clubbing or cyanosis at the start of the case. Look for potential IV lines and infusions that are already running on the patient, and then take a very good set of baseline values for blood pressure, heart rate, respiratory rate, and put the SATS probe on before you start the case to see, is the SATS reading 96 or is it reading 86, and why is it 86 at the start of the case? Is this patient already potentially in pulmonary edema? What's the reason for this? So a good set of baseline values before the start of the Caesar. The airway examination is part of every spinal anesthetic and every general anesthetic that you will perform. So there are many ways of performing the airway examination. One of them is the sort of acronym LEMON approach with look, evaluate, Mallampati, obstruction, and neck mobility. And in there, start systematically. It doesn't really matter how you do it. I like to start from the outside, evaluating soft tissues, looking for any obvious swelling around the neck and the mouth, anything that can cause me difficulties to enter the mouth. The swollen bitten tongue, teeth missing or buck teeth make it very difficult for the laryngoscope blades and the tubes to go in. And then even hair can be problematic with a wig that can be at the back of the head, which can prevent neck extension. So look, open up, remove clothes, and have a good evaluation. Then thyromental distances, incisors, to enter the mouth, and the submandibular area, which is going to be very important. So testing of protrusion. Will the patient be able to move their mandible forwards as you lift on your laryngoscope blade? The Mullen-Party score, if there's obvious signs of a Mullen-Party 3 and 4, that's going to add to the difficulties. Obstruction, listen to the patient's airflow, listen to the hoarseness, any changes in voice, and neck mobility, examining the joints of the airway, like the atlanto-occipital joint movement for full neck extension, flexion. Will the patient, once positioned, ramped, be able to lift their chin above their occiput, getting them in that optimal sniffing the morning air position? So summarizing the airway evaluation, on this poster one can see that can the mouth open? Are the teeth okay? Can the neck move? Is there good flexion and extension? Can you get the tongue out of the way? Will there be enough space in that submandibular area for the tongue to be displaced when performing laryngoscopy? Moving on to cardio-respiratory reserve. This is very important to evaluate the patient's reserve and the current state. During pregnancy, mom increases her cardiac output to ensure oxygen delivery to the placenta and to the fetus. She does this with increasing her heart rate and her stroke volume. And this stroke volume will be dependent on her preload, the blood that returns to the right atrium and ventricle, which is increased in pregnancy due to increase in blood volume, the contractility of both the right and the left ventricle, that may be influenced, like in certain conditions, especially for example preeclampsia can change contractility in pregnancy, and afterload, which is normally decreased in pregnancy due to a decrease in systemic vascular resistance caused by vasodilatation. So all of these are important to assess and to evaluate, and it's important to practice this. As for every patient you do examine and get an idea of what is the heart rate like, what's the volume of the pulse, what is the rate and the rhythm of the pulse. Gives you an idea of where this patient is at. Is the heart rate at the beginning of the case 80, 90, or is it 150? Don't miss that slow rising plateau pulse of aortic stenosis, and be cognizant of changes in pulse volume. Warning signs here will be poor capillary filling, cold clammy peripheries, which may guide you to a patient that is dehydrated, whether they've been starved nilperos for a long time or there's currently bleeding, but these are all signs of hypovolemia or poor cardiac output. If the pulse rate starts rising above 100 per minute, be thinking of clues to this. Why is this heart rate now 130, 140? Again, we consider hemorrhage, but other cardiac conditions, arrhythmias, underlying cardiac conditions, which have gone through the antepartum period, or patient might not even have booked, and the first time that she's having a thorough cardiac examination is when she presents to theatre. The mean arterial pressure, the MAP, below 60 millimeters of mercury is definite warning sign. Why is she hypotensive? Is this a cause of hypovolemia due to bleeding? And you hear this repeated sort of message of hemorrhage, but this is what goes through my mind when I see the patient already hypotensive at the start of the cesarean section. Where is this coming from? What is the cause of the hypertension? When we look at the respiratory system, it's important to appreciate the mechanism and are there any signs of respiratory distress? a normal healthy pregnant patient should not have a respiratory rate of more than 24. So why is this lady now on the table going at 30, 35? What is happening here? Why is she using the accessory muscles? Is there already pulmonary edema, or is there a lower respiratory tract infection? Why is she so distressed? These are signs to appreciate preoperatively before you start the case. Make sure to examine the neuromuscular function and the lumbar spine before you start your cesarean section and anesthetic for the Caesar as well. Why is this lady drowsy at the start of the case? Is she just tired from a long labor, or is she hypoxic at the start of the case and hypotensive, hypovolemic, and this is the cause for the drowsiness, or causing uncooperative and even aggression in certain patients? So be aware and be monitoring this. Ensure that you sort of work on a diff diagnosis when it comes to level of consciousness and cooperation at this stage. Most patients will be willing to move over the bed, cooperate, sit upright and help you. Obviously with intermittent contractions causing pain, but they should never be aggressive and uncooperative. There must be a reason for this. So try to get to the bottom of this before you start your case. Examine the lumbar spine, assess the back antenatally if you have opportunity, or pre-operatively to assess for spinal anesthesia. This is a good time to find your spinous processes and your spaces. You want to look for those L3, 4, 4, 5 and 5S1 spaces where you're going to perform your spinal anesthetic. Is the surface anatomy easy to appreciate? Is there central obesity in this area? Can you find the spaces at all? How easy do you think from a anatomical point of view is it going to be to gain access? And then the same for venous access sites as well. It's good already to examine the arms before you start your Caesar. Look for those veins, potential veins. You're going to have to find at least one large bore IV line, and in the patients with risk of hemorrhage, 2. So it's good to have these before you start the case and identify potential sites. The external jugular vein has saved many patients for me. The great saphenous vein on the foot. You sometimes find good veins as well where the arms might have been bruised with previous IV accesses or so. So look for all these potential sites that we've listed here. When it comes to special investigations or bedside investigations, the rule of thumb here is only what is indicated. We don't want to delay the case with unnecessary examinations which won't add any value to the case at all. An HB is essential, and a ward HB, we want to see a value of more than 10 grams per deciliter at the start of the case, as most patients will bleed between 500 to even a liter, up to a liter of blood loss during the Caesar. It's not uncommon to see that patients bleed more than this, so it's good to know what the HB is at the start of the case. Urine testing with urine dipsticks, checking for proteins, especially in the preeclamptic group, blood glucose for the diabetic patients, but then things like ECGs and chest x-rays just when it is really indicated, and should not be done routinely. In certain facilities there will be access to echo, and I want to encourage everyone to get involved in echocardiography. Like basic fate evaluations has hugely improved my sort of means of evaluating patients perioperatively, deciding on cardiac function, volume status, any valvular heart disease. So by all means, do improve your skill, but it does not mean that if you don't have access to this, that clinical skills and your clinical acumen, taking a history and examining the patient, is not necessary. So at this point, it is important to evaluate the patient for risk of bleeding before it occurs. And please do this for every single patient that you see. Ask yourself, is this patient low, medium, or high risk of bleeding? With patients at high risk for bleeding, with histories of placenta accreta spectrum, previous placenta accretas, known coagulopathies, platelet disorders, or currently actively bleeding. This obviously needs good IV access, blood ordering before the time, with other clotting factors needed. If this is known, then transferring this patient and referring this patient to a high level of care with expertise, because these patients tend to complicate and end up or could require a hysterectomy. If we look at the low risk group, these are your routine seizures with no previous uterine incision, singleton pregnancies, no bleeding disorders, and no history of postpartum hemorrhage. So in this patient group, we do not expect them to lose in excess of 500 to a litre of blood, which would be compensated for easily. And here, no extra care is needed except for monitoring blood loss during the case and checking the HB post-operatively. So in this spectrum of cases, you have to prepare, consider what IV access will be sufficient, and discuss with the surgeon the expertise, surgical expertise, and then if there is excessive bleeding, what would be the anesthetic and the surgical plans to manage it. So now, at the end, before you start your case, you've got to ask yourself a couple of questions. Do I understand this patient's condition? Do I have a good grasp of where this patient is at medically, surgically, and from an anesthetic point of view? What are the risks? Will this patient benefit from a discussion with a senior further? Is there enough time? Is this in the best interest of the patient? Or am I ready to move on with this case? What are the risks for bleeding? Is it safe to refer this patient to a high level of care, whether it is for obstetric care, intensive care, anesthetic care, special investigations? Can I optimize this patient in any way? Is there anything I can do or the team can do to improve this patient before we start? And then the question of, is it going to be the routine spinal, which is preferred in the majority of the cases, or will I do a general anesthetic because there's a special contraindication for spinal anesthesia and I'm going to perform a safe GA? Certain conditions will be picked up in the antenatal clinic already, and it is very important to refer these patients to a higher level of care. When there is morbid obesity, any cardiac disease, whether it is valvular heart disease, which is quite common, congenital heart disease, we refer these patients to a higher level of care. Respiratory diseases, the difficult airway, hypertension, preeclampsia, diabetes, or any previous anesthesia complication, any condition, and that is why it's so valuable to have antenatal clinics, and a component or a part of your antenatal clinic should include anesthetic assessments of high-risk patients, where your obstetricians refer patients to you for selected consultation and anesthetic evaluations. So we've seen this in the Saving Mothers reports and confidential inquiries, that it is better to refer these patients early on rather than sitting on them in the district and smaller hospitals where you do not have access to the resources to manage these patients optimally. Okay, so take-home message for patient preoperative evaluation. Know your patient well. It's not just another cesarean section. Each case is special. Do I proceed with the case or do I refer? What can be done to improve this patient's current condition? Is there anything I can do to improve it? And spinal is preferred, but know when and how to do a good GA.